This video presents Lea Hyvarinen test system that has been developed during the last 20 years. The test system consists of tests that are used in basic healthcare by district nurses and pediatricians, and of tests used by ophthalmologists, pediatric neurologists, psychologists, and special educators who often examine visually impaired, multiply handicapped children together. We shall first look on the tests used in basic healthcare. Observations on the development of vision start soon after birth. The pediatrician makes sure that the structure of the eyes looks normal and that light reflexes in the pupils are clear. At the age of 8 weeks, the infants should respond with a social smile. And at the age of 3 months, visual communication is very active. The infant can follow an object both horizontally and vertically, can converge and grasps. The eyes look straight at the same object. And the infant can perform quick saccades across the midline. If an infant's eyes are big and close to each other, and the nasal bridge has not yet formed, the infant may appear to have an inward squint, esotropia. However, if light reflexes are in the middle of the pupils and the eyes do not move during the cover test, then the eyes are straight. During the follow-up examinations in the healthcare centers, the vision of the two eyes can be best compared when the infant is playing with something very interesting. If the infant uses both eyes symmetrically, there is usually no response when either of the eyes is covered, or the response is symmetrical. To disturb the infant as little as possible, it is advisable not to touch the face while covering the eye. If strabismus or unequal visual function is suspected and confirmed by an ophthalmologist, the deviation from normal development can be corrected with glasses and by training. A lazy or amblyopic eye can be trained by covering the better eye and using a reading lens in front of the lazy eye. This boy is wearing translucent cover on the lower part of the lens of the right eye and a reading lens in front of the left eye. If an infant has hyperopia or 4 to 5 diopters, the efforts to compensate by accommodation may make the little forehead wrinkle, much the same as it would in an adult. In screening and diagnosis of amblyopia, the lazy eye, we use optotype tests. Their use is possible when the child has developed a concept similar, different, and can either match the symbol to a symbol set that he has himself, or can name the symbols, either by using spoken words or signs. It is possible to train the test situation by using the three-dimensional Lea symbols puzzle. When we start to train the concept, similar, different, it is best to introduce the three-dimensional puzzle by giving just one choice. Later 2, and finally all 4 different cutout spaces are presented. At the age of 1.5 years, puzzles are difficult. The little hand is still rather clumsy. And children often use more force than skill in this task. Since we use smaller and smaller pictures in the different vision tests, picture perception can be trained by drawing pictures of objects for the child. The Lea test symbols can be trained in such a play situation. The child may then color the picture, although at this age it is not really coloring but scribbling. But after all, participation is more important than the coloring skill. Then we draw smaller pictures and demonstrate that the three-dimensional form can also be placed on small pictures. If a child does not recognize the picture as a representation of the object, he will not place the form on the correct picture. A year later, at the age of 2.5 years, motor functions of the hand are much more developed, but the task still requires concentration. At this age, the readiness of recognizing pictures as representations of objects is present. The child can now place the forms on the correct pictures, both large and small. In this way, it is possible to measure visual acuity in a play situation. First, with both eyes open, later using each eye separately. If the child is shy, the TNO test often functions well as the first game, because it is both exciting and fun. The child is asked to point on the balls that are visible without the red-green lenses, then to all balls that become visible through the lenses. The motor abilities of the little hand need to be checked before the quantitative stereo pictures can be shown. Oculomotor functions and strabismus are checked in the same way as in the assessment of an infant's vision. Eye movements are normal and convergence. The small picture of a giraffe or bunny is now used for fixation. In this case, the eyes are straight. Next, visual acuity is measured, and therefore the names have to be agreed upon. Near vision acuity is first measured binocularly. When the symbols become small, close to the threshold value of the child bends towards the test. Distance visual acuity is measured first binocularly, and then in the right and left eyes separately. An easy way to cover an eye is to use spectacles with one lens occluded. A difference greater than 2 lines in the visual acuity values of the left and the right eye is the usual criterion for referral. Even smaller differences in the function of the 2 eyes make an experienced examiner have a second look at the child's visual performance. It is possible that the small difference is related to a beginning amblyopia, which would be easy to treat. If the regular line test chart is too difficult, it is possible to use an easier test with 5 symbols in a group. The middle symbol functions as the symbols in the line test. Children with difficulties in communication may use signs, which are agreed upon at the beginning of the examination. When a child reports that the pirate patch disturbs her vision, the tester should respond sympathetically. Even children who are treated by an ophthalmologist or optometrist have their vision checked during their regular healthcare checkups. In this way, the visual acuity values obtained at the healthcare center and in the eye doctor's office can be compared. In Finland, information between these 2 places is exchanged via the child's healthcare follow-up booklet. The small line test is too easy in the assessment of older preschool children. Therefore, there is a larger test with a separate set for binocular testing and for both monocular testings. The effect of variation in illumination on the test results can be avoided by using a back-illuminated test on a light box. In diagnostic evaluation, we need not only visual acuity tests, but also contrast sensitivity measurements, also quantitative color vision tests, and in certain cases, measurement of visual adaptation. Visual acuity of an infant can be measured with grating acuity tests. Low contrast vision with hiding pictures. Grating acuity measurement is quick and easy. Low contrast hiding pictures are useful for measurement of vision needed in communication. Lea test system's most important feature is the fact that the same symbols can be used throughout the preschool years, both in basic healthcare and in clinical evaluation. By using the child's play and therapy situations, we can start much earlier than before, and we can assess the child far more thoroughly.